مساء الخير. Our patient is a 15-year-old male patient, presented complaining of left sudden onset metamorphopsia. He denied any history of ocular pain, redness, or double vision. He denied any history of fever, joint pain, or any viral prodromal symptoms. He had positive history of contact with cats and rabbits for the last 2 years. He had pre-past ophthalmic or surgical history, pre-family history. On examination, he had both eye quiet conjunctiva, both eye clear corneas, quiet AC. The IOP was normal. Upon his fundus examination, the right eye was normal. The left eye, as we can see that there's elevated disc with star-shaped macular edema in his left eye. On June 20th, also his OCT showed in the right eye was normal. The left eye showed multi-serous retinal detachments. And visual field was done, Ishihara was done, all laboratory tests and imaging studies were done, and all were negative. Even MRI, chest X-ray to rule out sarcoidosis, TB, anti-MOG antibodies, HLAs, everything was done. I also asked, how common is neuroretinitis in the Arab world? There is no reliable epidemiological data that tells us how common is neuroretinitis is specifically in the Arab world, in the Middle East or North Africa. Then I asked, do we have Bartonella disease in the Middle East? Do we have Bartonella test serology available? Unfortunately, I only found in the WHO studies about endocarditis in the Arab world. I haven't seen any published data on eyes. And Bartonella test is not available in Palestine. It's available in, I think, in Dubai. Jordan, I'm not sure as well. So it's not even, the serology test is not available in all the Arab world. Neuroretinitis is an inflammation of the optic nerve and the neuroretina or macula of either infectious or idiopathic etiology. It was originally described by Leber in 1916 and then challenged by Gaz in 1977. 88% they have central visual field defects. Signs of optic nerve dysfunction are usually mild or absent. Visual disturbance is usually due to macular involvement. Papillitis is associated with peripapillary and macular edema. Venous involvement and splinter hemorrhages may be seen in severe cases. A macular star is typically seen as the disease settles. The star resolves with a return to normal or near normal in 6 to 12 months. It's more common in young males, although some recent papers say that it's more common in females. Where is the primary location? After all the debate, all the many years, it's in the optic disc, and then we see it in the macula. Visual field defects can be seen in many aspects, mostly central. Classification is either infectious or idiopathic. In infectious, we see more than 60% are due to cat scratch disease caused by Bartonella species. Common systemic symptoms include a pump or blister due to bite, swollen lymph nodes, fatigue, headaches, or a course of fever. Other infections could be viruses like herpes, hepatitis, herpes zoster, corona as well. Parasites like Toxoplasma, Toxocara, fungi, and bacteria. Para-infectious causes, autoimmune-mediated, sarcoidosis, SLE, Behçet, polyarteritis nodosa, Takayasu, VKH, inflammatory bowel disease should be kept in mind. In idiopathic neuroretinitis, cases in which a clear infectious or inflammatory etiology is not found are categorized as idiopathic. It's a diagnosis of exclusion made after other known causes of neuroretinitis are ruled out. It usually affects children or young adults. Most cases of visual loss are unilateral. Vision is usually between 250 to 200, though vision has been shown to range from 220 to light perception. The most common visual field loss is central, and an RABD may be present. It's not as prominent as a demyelinating disease. Examination usually manifests posterior chamfer cells and occasionally anterior chamfer cells, and recurrences are very rare. Differential diagnosis we should keep in mind: ion, hypertensive retinopathy, PRVO, CRVO, papilledema, compressive optic neuropathy, infiltrative optic neuropathy, and non-specific uveitis. Treatment: IV methylprednisolone and doxycycline 100 mg by 2. On July 3rd, 2 weeks post-presentation, I come back to my patient. We can see that the OCT showed almost resolution for the multiple serous detachment with minimal subretinal fluid remaining. The management depends on the cause, whether infectious or idiopathic, with antibiotics and steroids. Prognosis: optic disc edema is generally self-limited. Otherwise, another etiology such as optic disc tumor or sarcoid should be considered. Most patients with idiopathic neuroretinitis achieve excellent visual recovery with or without intervention. In infectious neuroretinitis, One report cites 93% of patients achieving 20/40 visual acuity and no patient with less than 20/200 vision. Thank you.
Thank you, Dr. Salam. That's great.
You're welcome.
Agree with you that it's not common to have cat scratch in our disease. I would like just only to to track your attentions. We published the papers about neuroretinitis this year, 2025, ocular inflammation journals, and including 10 patients. And the most common cause of the neuroretinitis in our community is Behçet disease-related neuroretinitis.
Yeah.
It's the most, followed by toxoplasmosis, and then by. But this terminology of the neuroretinitis is really it's not clear to all the the ophthalmologists. What is the neuroretinitis? Is it just coming from the optic nerve to the retina or the opposite? Actually, any lesions beside the optic nerve might lead to what we call it, optic neuritis, either primary or secondary. So it's great to mention it. The management, it's great that this patient need to be diagnosed as early as possible. Otherwise, it might lead to permanent, subretinal fibrosis, and it could be missed. Thank you very much.
Do you have access for Bartonella testing for in your country?
Yeah, we have. Yeah. It's there. Doxycycline is there. Any questions to Dr. Salam?
Another comment. I think this is Bartonellosis, because if Behçet, it will be more vasculitis than going to neuroretinitis, and it's unilateral. Usually it's unilateral, because I had a case, very similar case, that I was first faced with it, and I presented last year in my own. It's a very nice case, because at that time, when I went to literature, I retrogradely got the information, and it's very, very important because it's multi-system also.
Yeah.
It's having neurological manifestation, ENT manifestation. It's a multi-system affection, inflammatory affection, and the child must go for this battery of investigation as well.
But our child had negative Bartonella. He was luckily from Jerusalem, and he had access to the Israeli hospitals where they have the test, and he's done it.
Dr. Hassan mentioned a lot of causes for neuroretinitis, but in the typical neuroretinitis, the Bartonella type, fluorescein angiography shows nothing. In the macular area, it's not a vascular insult. It is not. It's a retinitis with the inflammation of the optic disc. You find all the retinal vasculatures are intact. While the opposite in Behçet disease, you will find vasculitis, capillary dilatation, leakage. So it's mainly inflammatory and vascular. Here it's completely different. You do fluorescein angiography, you get astonished. There is nothing in the fluorescein except the hot disk.
That was what made the mysterious of saying whether it starts from the macula or the disc for so many years.
And yes. But yeah, they link it to it. It's like an immune reaction. It sounds like it's an inflammatory immune reaction, I think, to steroid.
To antibiotic. And the steroids as well, to reduce the edema. The edema, of course.
When in such a case, I first went, like Professor Magdi just mentioned, to angiography, because I thought it might be a rare cause of telangiectasias. I found the periphery completely normal. Everything is perfect. I did OCTA. I find nothing in the macular area. It's very, very important, this also entity.
Apart from uveitis, what other things that can lead to suspicion?
Yeah, I mentioned all the differential diagnoses. Hypertension is hypertension.
Macroaneurysm, peripapillary choroidal neovascular. So what is
the differential is very long. That's why I chose this case for a retina session, not a uveitis session. Actually.
All of these will be manifested by and history. History is an important thing. Fluorescein angiography is objective. It's evidence-based.
And being unilateral.
He's young, unilateral boy with history of cats contact, but he was Bartonella negative.
But unilateral disease, even though there is reported cases of bilateral, but even though unilateral, think about infection.
Yeah. Usually we see it unilateral.
Because the time that we can move to the next speaker. Allow me.
Sure.
Dr. Noura,